Hello everyone, for this week's lecture we will be discussing sensory and skin. It will cover chapter 17 and 23. These are the objectives that you can find in your syllabus. Let's start with chapter 17, sensory. So we're going to discuss sensory perception, specifically visual and hearing impairments, and how they can affect communication and language development in children. So sensory perception, that is how we receive and interpret stimuli from our environment. So this includes information, we get through our eyes and ears, which are very crucial for understanding the world around us. So you want to envision infants, and as they grow older, utilizing all of their five senses to explore themselves, those around them, and their environment. So, when there are any eye or ear disorders, that can lead to altered sensory perception, meaning someone might experience visual or hearing impairments, and those impairments that can impact how well they can communicate and develop those language skills as they grow older. So it can cause those delays. Visual perception. We discussed this before in previous weeks. So let's start with the eyes. Visual acuity, that refers to the sharpness of a person's vision or how clearly they see things. So for infants, their vision is not fully developed at birth. At birth, their visual acuity is about 20/400, meaning they can't see things clearly. It's like big blobs, basically. They're nearsighted, only can see very up close. But by the time they're about 6 years old, their vision improves and that becomes 20/20, which is considered normal adult vision. So, however, you want to think of preemies, so preterm infants, the development of their eyes can be affected, right? They didn't get to bake in the oven or in the uterus or in the womb long enough compared to a full-term baby. So preemies, they might have incomplete retinal vascularization. So that means that the blood vessels in the retina haven't fully developed. So this can affect their vision and make them more prone to vision problems later on. And then also color vision develops around 6 to 12 months. So babies won't see colors clearly until this stage or this age. Moving on to hearing perception. So moving on to the ears. Hearing is intact at birth. We mentioned that multiple times, meaning in previous weeks, meaning babies are able to hear sounds right from the start. However, we talked about physical assessment. When you see low set ears, certain congenital deformities, in the ear, that can be linked to other body system abnormalities or maybe genetic syndromes. So if you see low set ears, again, thinking about in the womb, during that fetal development, if there's any issues during the development of their ears, you also want to correlate that with like their renal system, their kidneys. So if they have low set ears and there's something wrong there, that deformity, then you want to be able to document that appropriately, and so the physicians can order labs or any types of imaging appropriately so that they can rule out genetic syndromes or anything going on with their kidneys or GU system. And then, so it's just important to consider that bigger picture. So if a child has, in the case if a kid has a hearing problem. And then for infants, you want to think about their eustachian tubes. So those are the tubes that connect the middle ear to the throat. They're more shorter, wider, and more horizontally placed. So this makes them more prone to ear infections because organisms can travel through that more horizontally placed eustachian tube. And as children grow, these tubes will start to elongate and they'll become more vertical like adults. So that will help reduce the risk and the frequency of infections. So you want to think about bottle propping for infants. If they're doing that, it can start pooling, the milk can start pooling in that area because, again, of how it's placed, and that is just welcoming bacteria, organisms, and again, increasing their risk for ear infections. All right, let's move on to conjunctivitis. So basically, that's just like inflammation of the conjunctiva, right? That thin tissue covering that white part of the eye and the inside of the eyelid. This can be caused by various things, an infection, maybe allergies, or some type of chemical irritation. So the different types, as I just mentioned. So in terms of infectious conjunctivitis, you want to think of this is also known as pink eye, right? This can happen to one or both of the eyes, so unilateral or bilateral, and this type is very contagious. So it can be caused by a virus or maybe a bacteria. So if it's a virus, common ones are like adenovirus, influenza, and then in terms of bacteria, common ones are like Staphylococcus aureus, Streptococcus pneumoniae, and Haemophilus influenzae. And then in newborns, the bacteria it differs. Like chlamydia, trachomatis, and gonorrhea. In terms of the symptoms, what are you going to be able to see? What are they going to disclose, or parents and or the kid? You want to think of you're going to see redness of their sclera, swelling, maybe itchiness, so pruritus, pain whenever they're blinking, excessive tearing, and then also discharge. So if it's you might see like purulent discharge, and then their eyelids are going to be stuck together after sleeping. So when they wake up, it's going to be all crusted, like glued eyes, basically. And then also they may feel like a foreign body sensation, like they think that there's something in their eye, but there's not. So that's one of the symptoms as well. To determine, the cause, is it viral or is it bacterial? Physicians might order a culture of that eye drainage, so that can help them to choose the right antibiotics if it is a bacterial infection. In terms of risk factors, what increases their risk to getting this type of conjunctivitis or pink eye is infants less than 2 weeks old. You want to think of kids that are in school, especially like daycares or child development centers, because they're constantly touching stuff, sharing toys, and then touching all their body parts, including their eyes. So that spreads germs very easily, all those different organisms. And then other infections like an URI, an upper respiratory infection, maybe pharyngitis or an ear infection, otitis media, that can increase the risk. In terms of complications, so that's typically rare, but if it's untreated, this can cause more serious eye problems. So being able to catch this early and getting the appropriate treatment depending on the cause, that can really help. In terms of the treatment, typically it's like a topical ophthalmic antibiotic, so it could be in drop form or ointment. So it could be like tobramycin or maybe erythromycin, just depends. It could be either or. Another type of conjunctivitis is allergic. So this one is typically bilateral, so both eyes. So that sometimes can help you symptoms wise of ruling out in terms of if you only have one pink eye, like only on the right eye, not both, then you can rule out allergic conjunctivitis depending on like the cause. So this happens, when a child is exposed to like a specific allergen, maybe like pollen, pet dander, or dust mites. Children with a family history of allergies, they're more likely to develop it. And this could be seasonal, like seasonal allergies, or it could be year-round. It just depends on what the child is allergic to. So if it is mold and animal dander and they are constantly exposed to it, then that's going to trigger it, right, or cause it. In terms of symptoms, it's pretty similar with the pruritus, so itching, redness, that watery discharge. So the discharge is not purulent, it's more stringy and thick. And then also you might see some edema or swelling of their eyelids. This one's more common in school agers and adolescents, especially those with allergies. So in terms of treatment, they can do for the allergic one is artificial tears for like that lubrication, and then also it may be like systemic or topical antihistamines, just depending. And then in addition to that, like not just pharmacological interventions, you can educate about a cold compress to the affected eyes, no contacts, no wearing of contact lenses till it's resolved, and no makeup, and to throw away old makeup. So, in regarding to like those school agers or adolescents that are wearing makeup. So, in regarding to conjunctivitis, if it's not responsive to whatever treatment was prescribed or educated about within those 2 to 3 days, then they may need a referral to ophthalmology. Here is a table, just a brief overview of the different types, findings, and then treatments. So just being able to distinguish between the three. There are some similar symptoms, but there's also some differences, and also differences in causes. So make sure you know that. Let's move on to nasolacrimal duct obstruction. So this condition is very common in infants, and it just happens when that nasolacrimal duct, so that's what helps drains tears from the eye into the nose, it doesn't fully open. So that can cause those tears to build up in the eye. And most of these cases, majority of the cases, it just only affects one eye, so unilateral. In terms of the symptoms, so the most noticeable symptom, it will be that chronic tearing of that affected eye. And because that tear duct is blocked, how I mentioned, those tears build up in that sac or that lacrimal sac, and then that drainage that you're going to see, it's gonna look more like mucoid or like mucus or mucopurulent drainage. So it can be thick sometimes, or it may look yellow or green, like resembling a mild infection, so to speak. And then I mentioned already that the continuous tearing, right? The chronic tearing. And then in terms of to diagnose this obstruction, you're going to have to rule out like an actual infection. So possibly a culture of that drainage. Just to confirm, like, is there any, is it positive for any bacterias? Is it it's confirm, like, is it conjunctivitis or like a secondary bacterial infection? You want to be able to rule that out, and if it is positive, then be able to prescribe the appropriate medications and give that and educate it to parents. So in terms of management, it's typically self-limiting, meaning it'll resolve spontaneously as that duct matures more, usually within like that first year of life. So in the meantime, you want to be able to monitor, like watchful waiting. So just being able to see, like, does it clear up up on its own or not. Until then, you want to be able to educate about massaging that duct, that nasolacrimal duct, to help clear that blockage. So just educating about gently massaging that area, so that'll help encourage that duct to open up, which that can help reduce that chronic tearing. But if there is an infection, like a secondary bacterial infection, because of that blockage, you may see that physicians will recommend those antibiotic ointments or drops to help treat that specific infection. Not the duct, but the infection that the duct caused. Also, you want to be able to educate about making sure that the parents are cleaning the eye regularly, consistently with a moist cloth to help remove any of that discharge, to be able to keep that area clean. About 6 to 12 months, if that does not improve, like 6 to 12 months of life, then if it doesn't improve with the massage, or if they were prescribed antibiotics for that secondary infection, then you may see a referral to ophthalmology. All right, let's move on to hordeola. So this is also known as a stye. It's just an infection of the sebaceous gland, basically. It's pretty common, in kids, and it's just more important to know how to identify it compared to Achilles yawn, which we'll talk about in a little bit, and also the management aspect of it. So this is a painful infection. Okay, it's when like that sebaceous gland in the eyelid gets blocked and infected. So it's usually caused by a bacteria, and you'll see it's like at the base of an eyelash, basically. So you may see like in a large lesion along that eyelid margin. So in terms of symptoms, how I mentioned, it's going to be painful when they either move their eyelid or that specific nodule is touched, you may see some redness along that eyelid margin, and then maybe some edema of the eyelid. Very uncomfortable for them. In terms of management and treatment, you want to be able to educate to them like, okay, you need to do a warm, moist compress about 15 minutes, 3 to 4 times a day. Okay, 15 minutes for 3 to 4 times a day. So that can help relieve some pain, that discomfort, help decrease that swelling a bit, and help encourage more of that drainage from that blocked gland, basically. And then in terms of if it is caused by a bacteria, so it is a bacterial infection, physicians will order antibiotic ointments or drops to be applied directly to that affected area. So for this one, it can take several weeks to resolve completely. But with that right education, making sure that you're applying the medication prescribed, the warm, moist compresses, sitting on top of it, that can help, improve it. Maybe gradually, not as quick, but it will improve. If it is on a older child and they wear makeup, just like earlier, no makeup, trash the old one, and no contact lenses until it resolves, okay? All right, let's move on to chalazion. So this is a painless infection of a I'm gonna butcher it, meibomian gland. Sorry. So it's going to be on the eyelid. Okay, it's deep. It's located deeper in that eyelid. So in terms of this, it's usually a small nodule or like a lump that you'll see. And then, how I mentioned, it is painless. Okay, but you may still see some redness along that eyelid margin. You may see some swelling as well. It may look a little puffy or enlarged, as you can see in that picture. In terms of management and treatment, same thing, just like the hordeolum in terms of the warm, moist compress. For this one, you may want to do it about 2 to 3 times a day for about 20 minutes for about 2 to 3 days. So 2 to 3 times a day for about 20 minutes for 2 to 3 days. This one will typically, it is self-limiting, can resolve spontaneously. But after, doing those warm compresses, after several weeks. But, if it's a very large nodule, if it's recurrent, or if there's an infection, they may prescribe, or a physician, antibiotic drops or ointments. If it's unresponsive, they may get a referral. And then within that referral, they're going to decide, do we need to surgically remove it, like a surgical excision, or maybe they may do a corticosteroid injection to help decrease that inflammation, because we don't want it to affect their vision. All right, let's move on to blepharitis. So this could be, it's inflammation of the eyelids, basically. So specifically along the eyelid margin. So it could be acute or chronic, but bilateral. Within this, you are going to see scaling and discharge along that eyelid or the edge of it. It's going to be crusty, and it may be, in terms of the discharge, it could be yellow or clear. Other symptoms that you may see, it might be swollen along that eyelid margin, and redness. They may experience some itching, so pruritus, or maybe a burning sensation. And then in terms of manage and treatment, another thing, there's a couple types of blepharitis. So if it's caused by Staphylococcus aureus, that's a primary cause, and the scaling, it'll be more dry compared to seborrhea, where that's more associated with like edema, psoriasis, dermatitis. The scales are going to look more greasy. In terms of treatment, warm, moist compress, just like the other few disorders that we just talked about, that will help soften those crustings and then make it easier to clean that area. And then if there's an infection or a lot of inflammation that they see, they may prescribe topical antibiotics, like ointments. This one, it can take about several weeks to resolve. All right, now take pause on this slide and take a look at these different eyes and see if you can identify, what type of eyelid disorder this is, what are the symptoms, and then how is this treated. All right, let's move on to congenital cataracts. So this just refers to, that the opacity of or clouding of the lens of the eye, that is present at birth. So typically, the lens is clear, right? But with this disorder, it will become cloudy, and it obstructs the light from reaching the retina, and that's what causes that impaired vision. So if this is left untreated, that can lead to like a lazy eye, so sensory amblyopia, where I'll talk about that a little bit later on. And then that can later on lead to that developmental delay, visually wise. In terms of bilateral cataract, so affecting both eyes, that is more so associated with like a metabolic or genetic syndrome. So, for example, like galactosemia or Down syndrome. In terms of symptoms, what you're going to be able to see, they're going to have, or what they're going to report, poor vision. That's that primary symptom, what you're going to notice. Or parents are going to report that, not the newborn. And sometimes for infants, they're going to show a lack of eye movement as well, maybe abnormal eye alignment, or they're just not reacting to visual stimuli, basically. And then in terms of causes, so like congenital, this disorder, it can be caused by infections during pregnancy, maybe like rubella or toxoplasmosis, or maybe a metabolic disorder. But in some cases, it could just be, it's unknown, so idiopathic. In terms of management and treatment, surgery, that is that primary treatment. So basically what they're going to do, that cloudy lens, it's removed. And then they may need like a lens replacement or corrective or glasses to help with that focusing afterwards. So the timing of that surgery, that's very critical. If it's not treated early enough or appropriately, like efficiently in time, that can lead to permanent visual delays. And then, like I mentioned, like the lazy eye. So being able to educate about follow-up care, making sure that they have those appointments, and then also monitoring for those possible complications like glaucoma. All right, retinopathy of prematurity, or ROP. So this is a retinal disorder that mainly affects preemie babies or premature infants. More so those that are before 31 weeks of gestation, or if their birth weight is about less than 1,500 grams. So within this, typically the blood vessels, or the retinal blood vessels, they begin to grow at around 16 weeks gestation, and then they're developed by 40 weeks, full term. But when that's incomplete, with preemie babies, that retinal vascularization that I mentioned, that can lead to that abnormal blood vessel growth or scarring. And that abnormal growth, that can cause complications like vision impairment or even blindness if it's not treated. So in terms of symptoms, those more in the early stages, like more noticeable, it doesn't show. So like, that's why routine screening for those infants is very important. But in more severe cases, you may see like cross-eyed, like strabismus, or in terms of tracking, they're going to have poor eye tracking, and then other visual abnormalities. So in terms of risk factors, the main cause of that is prematurity, but also there are other factors that can help or that can increase that risk. So how I mentioned that low birth weight, or infection like sepsis, or hypothermia, so like that low body temperature. In terms of management and treatment, so being able to detect this early enough, okay? So being able to have consistent and serial eye exams by an ophthalmologist, that is what is key for preemies. Usually it'll start like at around, I want to say, after a month, or 4 weeks after birth. In terms of if this disorder, if it progresses, they may need to opt for like laser surgery to help prevent further growth of like those abnormal blood vessels, or they may do like freezing treatment in some cases. It's called cryotherapy, and then sometimes they'll opt for like surgery. So there's the surgery is called vitrectomy surgery, and that will help remove that scar tissue and prevent any retinal detachment as well. But so if this is not detected, if it's not treated early enough, this can lead to a lot of complications as listed on the slide. So it could lead to nearsightedness, so myopia, glaucoma, blindness, the cross-eyed, how I mentioned strabismus, sorry, refractive errors, and then that lazy eye, amblyopia. All right, so strabismus, we kind of mentioned that. This is where the eyes are not properly aligned, so meaning like one or both of the eyes, they may not point in the same direction. They're pointing at different directions. So the most common types of strabismus, as you can see on the slide, like the right hand side, that picture, but the most common types is esotropia. So that's when both eyes are turned inward, and exotropia. So that's where one or both of the eyes are turned outward. So you want to think of exotropia, like so EX, so exit. So it's trying to exit outside of the face. So outward. Um, so this disorder can be congenital, present at birth, or it could just develop later in life. In terms of, when you want to think of this as a red flag, sorry. Is when it's after 4 months of age, or if the strabismus or that misalignment of the eyes is constant at any age. So that's what's going to opt for a referral to an ophthalmologist. But part of normal development, that some degree of this misalignment, it's common, again, as long as it's not constant and as long as it resolves by around 3 to 6 months of age. Okay. And then in terms of risk factors, you want to think of genetic factors, that can increase that likelihood, or maybe neurological or other conditions that may affect eye movement. If it's like brain or nervous system that's affected, then that can result in that eye movement issue. Vision problems, if they're nearsighted or farsightedness, that can lead to misalignment. And then prematurity as well. They're at higher risk for developing strabismus. Other symptoms other than seeing misaligned eyes, whether it's going outward or inward, you may see them squinting, especially like in bright light. They may close their eyes so that one can see better, or so they can see better by squinting their eyes. They may complain of like eye strain or headaches or difficulty focusing. In terms of for like older kids, that's what they may report. And then they also may report like double vision as well, because obviously an infant can't report that. So if this is left untreated, it's not found, they didn't see that in the assessment findings, or it's not treated in a timely manner, this can lead to complications like a lazy eye, or so amblyopia, or any visual deficits, or maybe some cosmetic concerns. So you want to think about if they have that noticeable misalignment. For those older kids that are very more aware or getting more aware of their body, that can affect their self-esteem, right? Think of disturbed body image and those social interactions if they start to get bullied. So in terms of management, they're going to do patching. So what they're going to do is patch that stronger eye so that they can encourage that weaker eye to work more effectively. So it's not just relying on that stronger eye. They may have corrective lenses, so glasses, to help treat that underlying impairment of like if they're nearsighted or farsightedness that is like resulting or contributing to this misalignment. And then if not, they may do eye muscle surgery. So it's just going to adjust like the muscles that are responsible for that eye movement basically. So yeah, that can be something too that may be considered if the others are not working. Okay, amblyopia, or also known as lazy eye. So this is just when one eye has poor vision, even though the eye itself, like, it looks normal. So this is just when the brain, it just relies on the one eye, so the stronger eye, and it ignores that weaker eye. So this leads to that impaired visual development in that affected eye that the brain is not using, and that can result in permanent vision problems. So if it's not treated early or again in a timely manner or efficiently, if they're not compliant with it, this can be permanent. And then in terms of like causes, it could be due to strabismus, or it could be due to refractive errors, maybe astigmatism. So astigmatism is that uneven curvature of that the surface of the eye, and that's what leads to like that blurred vision. Or maybe some trauma to the eye, or maybe a drooping eyelid, so ptosis or ptosis, and then cataracts as well. In terms of what you're going to see, so it doesn't often have like obvious signs. Like the kids may not complain about their vision, but you may see them like squinting, closing one eye, especially in that bright light, like mentioned earlier, or they may have difficulty seeing, objects clearly at a distance, or the more noticeable, or in just some cases, you're going to see that misalignment of the eyes. So like strabismus. And then in terms of this, so treatment, how I mentioned, early intervention, that's the key, so that it can be treated as soon as possible. So just like with strabismus, patching, those are the options. They may do some atropine drops, so this will blur the vision of the stronger eye and then encourages the weaker eye to strengthen, or forces it to work because they can't rely on the stronger eye. They may do corrective lenses, so glasses or contact lenses that can help with those, again, like the nearsightedness, farsightedness, astigmatism, etc. Or they may do eye muscle surgery. So if strabismus, that misalignment, is the cause of this amblyopia, they may be required to have surgery to help align those eyes properly. So it just depends on the cause. And then, yep, that's it for this one. You see the cool patches. Let's move. Before we move on, take time to pause. Take a look at these different disorders. Are you able to identify what are the symptoms and what's the management? All right, otitis externa. So this is infection and inflammation of the external ear canal, or the skin in the external ear. It's also known as swimmer's ear. And you want to think of, this is very common during summer season when a lot of kids are swimming in the beach and the pool, because water gets trapped in that ear, and it can also, typically it's like water that's trapped basically. And then the common causes are bacteria, like I think it's listed on the slide. So you can see Pseudomonas aeruginosa and Staphylococcus aureus. But fungal infections, that can also contribute, but bacteria, that's the primary cause, are more common. In terms of symptoms, what you're going to be seeing, or maybe they're going to be reporting, itching of that ear. That's usually a more early sign. Maybe ear drainage can be more white or colored. They may have that feeling of fullness in that ear canal, so they may complain of like discomfort, or maybe a blocked feeling in the ear. They may have possible hearing difficulty. So that swelling or the discharge, that can block that ear canal, and that can affect their hearing. And then also pain, that is often one of the main symptoms. And for younger kids, you want to think about, they can't communicate with words necessarily. So what are some behavioral things that you're going to see? They may be irritable or fussy, but they may be tugging at their ear. So that pain, it could range in severity, like mild to severe, but it usually hurts more when it's touched or pulled, and you're going to see like the actual ear, like the pinna, it's going to be sometimes red too. In terms of physical exam, so usually a physician will use like an otoscope to assess for that swelling, the redness, and that drainage in the ear canal. But as RNs, we don't do that commonly inpatient or outpatient setting. But that, and then physicians may order a culture of that ear drainage to be able to identify, is it a bacteria or a fungi that's what's causing the infection, so that they can prescribe the appropriate medication. In terms of management and treatment, so pain management, of course, over-the-counter analgesics, acetaminophen or ibuprofen, Tylenol, Motrin, just managing that pain. You can also encourage a warm compress or a heating pad to that outer ear, and that can help provide some comfort too. In terms of treating that infection, so depending on the cause, it could be antibiotic or antifungal drops, and it'll just like help clear up that infection basically. In terms of to prevent, so to prevent a recurrence or just to prevent in general, like they never had this type of ear infection before, just reminding or educating them to keep that ear dry. So especially after swimming or bathing, drying the ears properly basically. So like gently taking a towel and then drying that outer ear, or they can tilt their head, to the side and let that water drain out. I'm sure a lot of us have experienced that, where we have some water stuck in there and then we like shaking our head to the side and trying to get that water out. Or sometimes, if it's super recurrent and they keep getting these types of ear infections, telling them to use earplugs or a shower cap, because if they know that their kid swims a lot, this can help with keeping water out of their ear. And then also just educating about no Q-tips or just the cotton swabs, basically. Avoid that because, when you insert it, that can cause that irritation or injury to that area, and that can lead to infection as well. But, so if this is not treated, those complications, it can spread that infection to areas nearby, and you want to think what's nearby there, what systems or what parts of the body. And then also it can lead to chronic otitis externa, so this can lead long-term issues to that specific ear canal with that one that's affected. Moving on to otitis media with effusion, so OME. This is when you see fluid in that middle ear space, but there's no active signs of infection, okay? So there's no fever, no pus that you see. Basically, that middle ear, it gets filled with fluid, and that can lead to them reporting like that feeling of fullness or pressure in that ear. But so while this is not an infection, like you're not seeing any sense of infection, typically OME, it follows after acute otitis media, so AOM episode, which we'll talk about in the next slide. Sorry, I should have switched the slides. In terms of risk factors, you want to think of passive smoking. So if they are exposed to smoke, so secondhand smoke, breastfeeding, that helps prevent this. So if because breastfeeding or like breast milk, it has like protective benefits basically to help against those ear infections. If they have frequent URIs, so upper respiratory infections, if they have those recurrent colds or infections, that can contribute to OME and also acute otitis media. If they have a lot of allergies too, and they have all those secretions, they're at a higher risk. So you want to think about the anatomy of the ear, depending on the age. And then, like I just said, the anatomy, those kids that are under 2 years old, they are very vulnerable because, again, of the anatomy. And then in terms of symptoms, so other than that feeling of fullness, maybe they may have a popping sensation, they may have hearing loss, and that can lead to speech and language development. So if you notice any red flags or some delays within their communication and language, you want to be able to rule out, like, do they have a current ear infection? Did they just get over an ear infection and this is a complication that resulted from it? Is it temporary? Is it permanent? Things to that nature. And then another symptom that they may exhibit is tinnitus. So this is ringing or buzzing in the ear. All right, so in terms of complications, how I mentioned hearing loss and then deafness. In terms of management and treatment, so typically this will resolve spontaneously within like 3 to 6 months without, they don't need to be prescribed any medications. So being able to monitor, so they may need to do follow-up appointments every 4 weeks or maybe sooner if they notice any other changes or other concerns. In terms of education, just being able to educate them about monitoring their hearing and their development as well. And then if it just persists, that fluid, they may need to do surgery. So like a meningotomy can be performed. So that's basically where they're going to place small tubes into that eardrum to drain that fluid. All right, acute otitis media, so AOM, that is an infection, acute infection in the middle ear. Okay, so it's a rapid onset of ear pain and possibly a fever as well. Okay, it can be caused by a bacteria or virus. So common symptoms that you may see, like I mentioned, they're going to be febrile. They're going to have ear pain. So are they tugging at their ear? Are they able to verbalize to you that they are in pain? They may be more irritable, fussy, crying, again, especially in infants. That's their way to be able to communicate their discomfort. And because of the pain, they may not be eating well, poor appetite, poor feeding, because again of that pain. And then in terms of diagnosis, so the bacteria, usually it's more commonly caused by like S. pneumoniae or Haemophilus influenzae, and then M. catarrhalis. In terms of viral causes, typically it's like influenza or RSV. So in terms of treatment for viral acute otitis media, so this typically will just resolve spontaneously, so about a few days. So just supportive care, any pain relief, so any over-the-counter analgesics, Tylenol, Motrin, and then warm compresses to that affected ear to help with that discomfort. In terms of bacterial, typically it's an oral antibiotic, such as amoxicillin. Okay. Being able to educate, they need to take the full dose, whatever is prescribed. Just because their symptoms are getting better, that doesn't mean stop and to not take the full regimen of what was prescribed. And then in terms of prevention, you want to be able to educate about breastfeeding. They have lower rates of ear infections, being able to avoid secondhand smoke, avoiding bottle propping, like I mentioned earlier, good hygiene, and then, vaccinations as well to prevent, getting the flu and then resulting in an ear infection. All right, let's move on to chapter 23, integumentary, or the skin. So as you guys know, skin is the largest organ in the body. It's that protective barrier, basically. It just shields us from any trauma or maybe any organisms from entering the body. That's kind of like that first barrier, basically. But it also plays a role in terms of sensory, like that sensation of children and adults to be able to perceive, pain, temperatures too, heat and cold. But, there are some differences with kids compared to adults. So thinking about that variation in peds, their epidermis, that outermost layer of the skin, it is thinner compared to adults. So it's more fragile and more susceptible to injury. And because it's more thinner, they're more susceptible to heat loss as well. That's why they're more vulnerable to hypothermia. In terms of increased absorption, we talked about this. They're going to be able to absorb topical medications more quickly because of how thin their epidermis is as well. So you want to take that into account as well. And then in terms of skin changes, so as they get older, their skin will become more tough, like ours as adults. Yeah, okay. All right, so let's move on to the first skin infection, which is cellulitis. So this is typically very localized, and you'll see inflammation of the skin, and it typically occurs, after some type of skin trauma. So whether they were scratched, maybe with some type of abrasion, laceration, or an insect bite, like a bug bite near the eye or some part of the face. So just being able to be aware of these types of injuries and how it can lead to this infection. You don't want it to get to the point where they have to be hospitalized and get IV antibiotic therapy. Be able to prevent that. So in terms of causes and risk factors, so when the skin is injured, when there's broken skin there, that organism or bacteria that can travel or enter through that broken surface, basically. And then common ones are Staphylococcus aureus, Streptococcus pyogenes, and Streptococcus pneumoniae. And then in terms of what you're going to be seeing, the findings, you're going to see a lot of erythema, so redness, swelling, and tenderness at that affected area. It may feel very warm, and then painful as well. So typically it can be self-limiting, like it can resolve on its own, but if it is left untreated, like not monitored appropriately, it can lead to a skin abscess, become super big. If it's near the eye to the point where they can't see, they can't open their eye, then they are going to need to be hospitalized. So treatment is typically antibiotics. If it's a more mild case, then they may be prescribed oral antibiotics like Keflex or Augmentin. With severe cases, like I mentioned, if it's affecting their vision or it's just persistently getting worse, then especially again, like I mentioned, around the eyes, then they will need IV antibiotics. They need to go to the hospital and get admitted for a while. And so next one is impetigo. This is a bacterial skin infection, highly contagious, can be caused by Staph aureus or Streptococcus pyogenes. There are two main types, so non-bullous and bullous. And then in terms of this, they both can cause skin lesions, but the way that it appears, it differs, the causes and the treatment approach too a little bit. So in terms of non-bullous impetigo, so this is the most common type. This is a secondary infection to a skin trauma or an existing skin condition like eczema, so atopic dermatitis. So usually it will start out with like small bumps, so like papules, and that can lead into blisters, so vesicles, and then it can eventually lead to painless pustules that will break open, and it can or lead to it. You'll see like a honey color exudate, basically like drainage. So it's like more yellowish, and that's like that telltale sign of an infection. And it's typically found around like the nose, mouth area due to that friction. In terms of treatment, so typically it'll be like a topical ointment, so mupirocin, that's commonly used. But if it's more widespread and spreading more areas, more to like not just like the nose, it's leading more around the face or the mouth, they may be prescribed oral antibiotics. But to help with like that exudate, the honey crusted exudate, and to help soothe, that irritation too, want to educate about applying that cool compress twice a day, basically. In terms of bullous impetigo, so this is typically caused by Staphylococcus aureus, like I mentioned earlier. This leads to basically large fluid-filled blisters or bullae. That's why it's called bullous. They can appear more as like red macules, and it can range from like maybe a few millimeters to a few centimeters in size. Usually they will rupture and then it'll leave like a crusty lesion. Within this affects larger areas of the skin, so it could be like the trunk area or the face, a more larger part of the face. And then in terms of treatment, oral antibiotics for sure to help target the bacteria, being able to keep that area clean, soap and water, being able to monitor the kids so that they don't scratch at the blisters and open and spread that infection further. All right, fungal infections. So these are very common in kids and that can affect various parts of the body. So it's basically where the infections are caused by fungi, and it can just thrive in more like warm, moist areas of like skin, hair, maybe like the nails area. So it could be more superficial, so like those outer layers of the skin, or it could be more deeper. But most for in terms of children, it is more superficial and it is quite treatable. So the different or common types that you need to be aware of, it's that table right there. So let's think about ringworm. So Tinea corporis. So this is very common and it appears more of like a scaly patch. It's red, more circular. It usually is more raised and it gives like a ring appearance basically. Within this, you may see it more so in the arms, the legs, and that trunk area. It's very contagious, spread skin to skin, or like if it's contact with like objects that were infected with it, like towels. So, how I mentioned again, that symptom is like that circular rash with a red raised border. In terms of treatment, antifungal creams or maybe an oral antifungal med if the infection is more widespread. Okay, next one is scalp ringworm. So tinea capitis. So within the different disorder names, so tinea capitis, think of cap, another word for a hat. So, and it's found in the scalp. Okay, this is more common in younger kids. It can cause hair loss, and you may see like pruritus, so it's itchy. In terms of what you're going to findings wise, like scaly patches, there may be some pustules on the scalp as well. This is also highly contagious. Most commonly, it's shared or spread by combs or hats. So think of the scalp again, the head. In terms of treatment, oral antibiotics, or not antibiotics, I'm sorry, antifungals, and then topical treatments too. Okay, next is candidiasis. Let's do diaper rash. This is caused by a yeast infection. So Candida albicans. So usually it'll appear in that diaper area, and you're gonna see it looks much different compared to a diaper dermatitis. This is a more severe, it's very it looks pretty gnarly basically. In terms of what you're going to see, it is red, very inflamed, but also more of like a shiny, moist appearance. Like you'll see it looks more like plaques, and then it can spread to those skin folds. And it can be painful for the kids. And then this can be due to not allowing that perineal area to dry within diaper changes if they already have a diaper rash. So if they're just frequently exposed to that moisture and it's not allowed to dry. So typically what's ordered or prescribed is antifungal cream, so like nystatin, and being able to educate on how to use that. Sorry, I kind of went out of order. The next one let's go over is tinea pedis, so athlete's foot. Thinking of this one, it's more so common with like the older kiddos, right? School agers, adolescents. In terms of what you're going to see, it's going to be itchy, maybe burning, and more cracking and peeling of the skin, of what you're going to see between like the toes. So being able to do a thorough head to toe assessment. Okay, actually looking in between the toes. In terms of treatment, antifungal powders or creams. All right, pause, take a look at these different fungal infections, being able to identify it, what's the treatment, symptoms, etc. All right, let's move on to diaper dermatitis, or just diaper rash. So it's just a diaper rash, basically a rash where like that diaper lays, that more so that perineal area, can cause a lot of redness, irritation, and like pain too. You see how red and excoriated that picture is right there? So you want to think about, okay, what's causing this? Just like the Candida albicans or candidiasis, like that, the one in the previous slide, you want to think of moisture and also friction too. So if the diaper is very tight or like just a poorly fitted one, that can worsen that irritation. But it could be and then in terms of irritants, like that moisture, it could be like if the family is not changing their diapers often enough, right? You want to do as needed, or at least check every 2 hours. So that prolonged contact with like either the poop or stool, and then the urine, that can cause that irritation to that skin area and leading to that rash. So it's going to be very tender in that area. So one comment, I know we haven't talked about the GI system, but if it is a kiddo that is constipated, like moderate to severely constipated, they're on GoLYTELY therapy. So this is where they are stooling like every 30 minutes or very, very frequently. And if parents are not on top of it, changing them, their perineal area, that diaper area, gets very excoriated, to the point where every time you change a diaper, it's very, very painful and traumatizing to them. So that's why we really want to educate the parents how to properly clean, front to back, and then how often, what kind of barrier creams can we use, if there's any prescribed like Desitin, or just those like the berry cream like you see in between the Desitin and the perennial, the peri bottle. So like peri bottles, you see that in the postpartum unit, and then you see those dry clots. So when it gets to that point where you see that picture where it's super excoriated like that, using just like Huggies or like the baby wipes, those commercial baby wipes with like the scents, that can irritate that area even more. So when it gets to that point where it's super tender like that, what you can do instead is getting like lukewarm or warm water with that peri bottle, using that, either moistening those dry clots, or like moistening that area like directly, and then patting it dry, or cleaning it that way, rather, so that it's not as irritating compared to those baby wipes. Other things, like I mentioned, that's typically utilized is like that barrier cream that you often see in hospital settings, maybe some zinc oxide like Desitin. That helps create that barrier basically, so that it helps prevent irritation or more moisture. Allowing, the kid to go, or the baby to go diaperless. So after changing their diaper, without, getting sprayed on, if it's a baby boy, allowing that area to be able to dry and not just like cover it up with the diaper. Or if you're able to monitor them at home, letting them have more like diaper free time during the day, so that helps with that circulation and for the skin to heal more appropriately or more quickly. You can also use like a blow dryer to that rash area, like on the warm setting, obviously not the hot setting, maybe for a few minutes, 3 to 5 minutes the most, I would say, to help keep that skin dry. So kind of same idea in terms of going diaperless. If it's a fungal infection, like I mentioned, they're going to be prescribed that nystatin. And then in terms of other ways to prevent, so how I mentioned being able to change the diapers frequently. So as soon as it becomes wet or soiled, or at least every 2 hours, you want to double check it. Being able to avoid, I don't know who wears rubber pants nowadays, but yeah, or overly tight diapers, as I mentioned before, because that can trap that moisture and that friction. And then we talked about the gentle cleaning, and then avoiding those fragrance wipes. All right, let's move on to atopic dermatitis or eczema. So this is a chronic disorder, chronic skin disorder. So typically will appear like before 2 years old, and then this is typically a part of a family of conditions. So that's called atopy or atopic diseases. So this includes, if you have eczema, you also you're more likely to have food allergies or allergies in general, asthma. So those three. So allergies, asthma, and then atopic dermatitis. So the 3 A's basically. Within this, you want to think of, okay, what causes this? So it's can be triggered by a few different things. So it's genetic factors, and then also environmental irritants. So how I mentioned how the skin, that's a protective barrier, right? So as it gets like weakened, it makes the skin or the body more vulnerable, to those irritants and those allergens. So kids with eczema, they have overactive immune responses to certain foods, dust, pollen, could be environmental or foods. In terms of what you're going to see with eczema is itchy skin. It's super itchy, dry, scaly, flaky skin. So it'll often start becoming cracked too. You may notice like redness and scratch marks as well because it's super itchy. This thinking of like, okay, if they're super itchy at night, this is gonna cause sleeping issues and causing them to be more irritable during the day because they didn't get a good night's sleep. In terms of like the lesions, what they're going to look like, it could be dry patches, as I mentioned earlier, or it could be like small fluid filled bumps, so more like weepy papules, or like vesicles where it's like fluid filled blisters. In terms of like secondary bacterial infections, you may see if it's leading to that because they're scratching constantly and knowing like kids' hands are not the cleanest and they're using their nails to dig into there. It may be more red and more warm, and this can indicate a bacterial infection because, again, like I mentioned, the scratching, and this is what can lead to impetigo. In terms of like the location of the rashes of what you're going to see, so for those that are younger than 2 years old, it's more so seen like the face, the scalp area, their wrists, and extensor surfaces. So basically, like the outer sides of their elbows and their knees. If for older kids, so basically older than 2 years old, you're going to see more on their flexor surfaces. So the inner parts of their elbows and knees. In terms of management and treatment, so skin hydration is number one. So keeping that skin moisturized as much as you can using unscented lotions, so emollients like creams or ointments. So the thicker the better, not the diluted stuff. So being able to educate to them right after a shower, a bath, being able to hydrate them or like lather on that emollient. Topical steroids may be prescribed as well, but this is not like long term. It can only be used for X amount of days, X amount of weeks for flare ups, basically. So there's over the counter hydrocortisone, but as it gets worse, they may prescribe a more higher dose of hydrocortisone that a physician has to prescribe, or maybe triamcinolone. There's different types of ointments that you may see, and that can help decrease that inflammation. But again, like if it's used too much, that can start thinning out the skin. Being able to educate about preventing infection. So making sure they keep that area clean and to try to avoid scratching. So if it's a younger kid, younger than 2 years old, maybe putting on those baby mittens so that there's no contact from the kids or that baby's nails to the skin and causing that infection. And then being able to try to avoid triggers if they know what triggers them. So, any harsh soaps, anything scented, basically. Scented soaps, scented lotions. And then, in terms of their linen, too, or their clothes, too, there's unscented detergent to be able to wash those belongings, basically. Being able to also, like in the inpatient setting, if there is a kiddo with eczema and they're very sensitive to that, they can order like the hypoallergenic linens. It's just the same exact ones. It's just like they're washed in a different detergent. Being able to also avoid, extreme temperatures. If it's really hot and they're sweating, that moisture that can cause a flare up as well. And then allergens, anything that can flare it up, basically. And then within this as well, well, so the pictures, Aquaphor has a common emollient. There's CeraVe, that's a good one, and then Dove has a good body soap for like the sensitive skin because it's unscented. All right, moving on to contact dermatitis. So another skin disorder or skin infection. So this is when like the skin reacts to an allergen or an irritant. So it's like directly on that area. So and that leads to discomfort and then also inflammation. So it's basically just like that cell mediated immune response to exposure to an antigen, basically. So it can be triggered by various things that come into contact. So contact dermatitis with the skin. Okay, so common causes, as listed there, poison ivy, poison oak, or maybe animal dander like wool, feathers, or maybe fur that can cause that reaction. Maybe synthetic fabrics from clothing or bedding that can irritate the skin. You want to think about maybe metals. So you see, if you see it around their finger or maybe like on their wrist or their neck, and it's like right where their necklace or whatever jewelry they were wearing, that can cause that reaction too. Or maybe thinking about if it's located on their face, is it any makeup that these kids are wearing, any other products that they're utilizing that could be causing this irritation. So it could be like maybe certain soaps, maybe lotions in addition to the makeup, or maybe perfumes too. So it could be more localized, like to a more smaller area, or more like bigger too, like more generalized. In terms of what you're going to see, the lesions wise, it may be red, inflamed, like I mentioned. It can develop into like more bumps, blisters, or like open sores, just depending on how much you're scratching it too. In terms of like that affected area, it may be weeping as well, so like fluid or pus may drain from it. Crusting, so the skin may dry out and then it forms scabs. There may be some warmth and swelling to that area too. And then, of course, pruritus, so itching. And then in terms of management and treatment, you want to help promote that skin to heal, right? So avoid those triggers. If it is a ring or a bracelet, necklace, don't wear it. right? Eliminate that contact with that specific allergen if it's known, okay? They may be prescribed topical or maybe systemic corticosteroids, so oral corticosteroids. So topical could be like over-the-counter hydrocortisone or a higher dose, as mentioned with atopic dermatitis. But in more serious cases, they may be prescribed systemic corticosteroid, so an oral steroid. Same like with atopic dermatitis, making sure that you keep the skin hydrated, fragrance-free lotions, especially in that affected area. A cold compress can help too, to help decrease that swelling and itching, to help, provide some type of relief. And then in terms of to prevent, future flare-ups of this, and with the physician, they may consider, like patch testing to identify, if they don't know the direct cause, so they can identify specific allergens. Being able to use hypoallergenic products, as mentioned before in the previous slide. And then protective clothing. So if you're going to be out in the wilderness, touching all different leaves, bushes, whatnot, cover yourself or cover your child. And then just being able to educate to both that child and to parent how to avoid those triggers. All right, urticaria, so also known as hives. This is just like raised, red, itchy welts, that or on the skin basically, and it's just triggered by an allergic reaction, right? Type 1 hypersensitivity. So that's just basically it's a reaction caused by the body or the immune system, when it's exposed to certain allergens. So within this, it's cell mediated, meaning, like antigens, if it's like foods, meds, or infections that can trigger this like response, like that antigen antibody response, and that releases histamine from mast cells, and then that release, it causes vasodilation, so widening of those blood vessels, and then increases like the permeability, like vascularly. So that allows fluid to leak into those surrounding tissues, and that is what causes those classic signs that you see, the redness and those raised welts or the wheals on the skin. So it begins very quickly, but it can resolve in a few days, but sometimes it can last longer, up to 6 weeks, just depending. So like in terms of like causing, like what's triggering it could be foods, depending on what they're allergic to. Was it eggs? Was it nuts, strawberries, or maybe some type of antibiotic that they had for the first time, some type of antibiotic, or maybe it's like due to an animal, like a bee sting or some type of insect, or maybe some type of infection that's causing this. Maybe it could be emotional triggers too, like stress. So in addition to those raised red wheals that I mentioned, in terms of findings, you may see swelling under the skin, so angioedema, sorry, especially around like the eyes or the lip area. And then in terms of like the hives, it can vary in size and it can, move from one area to another. And then pruritus, that's a big one, very itchy, and then it can be very painful and discomforting for these kids. In terms of management and treatment, so antihistamines, that will be that first line of treatment to help decrease that itching and the swelling. It basically just like blocks that histamine response, as I mentioned in that patho. Corticosteroids, that's more so for like persistent or more severe cases, so PO. Oral corticosteroids may be used for more of that short period time, and then avoiding those triggers for sure, educating about that. Cool compresses, soothing lotions, that can help with that as well. So in some cases, those hives or this response, it can lead to an anaphylactic reaction, right? So that definitely deems that's a medical emergency. They need to seek that medical help, call 911 and whatnot. All right, seborrhea. So this is another form of dermatitis. It's chronic, and it typically affects, the skin or that scalp area. So in infants, this is typically called a cradle cap. But you can also see it on their nose, their eyebrows, behind the ears, and maybe sometimes in their diaper area. But for teenagers, this seborrhea, it shows up as dandruff, And this typically you'll see it for them and their scalp, their eyebrows, eyelashes, behind the ears, and sometimes like their shoulder blades as well. In terms of what you're going to see, so for infants, those it's like scales on the scalp. You can see on that picture, it's like very thick, yellowish, greasy scales. In terms for teens, it looks more like flakes on the scalp, so dandruff. But both types, like depending on like the age, it can cause more like mild redness and some irritation as well. But it's generally, not painful. Not painful, okay? In terms of, okay, how do we treat this? So for infants, educating about mineral oil that can be applied to that scalp area to help loosen those scales, and massaging or gently massaging that mineral oil in it, and then using a washcloth to help lift those crests after leaving that oil for like 10 to 15 minutes or so. But after, massaging, washing the scalp, like when you remove it, like the oil and stuff, you also want to use like a mild shampoo. But sometimes, if needed, more severe cases, they may be prescribed a selenium sulfide shampoo. In terms of teenagers, so educating them to use an anti-dandruff shampoo daily, basically. You want to look for like the products that contain, the selenium sulfide or ketoconazole to help treat that. Sometimes, like if it's more severe, like the inflammation is more severe, topical corticosteroids may be prescribed. But if we don't have to, and like the anti-dandruff shampoo works, then let's utilize that. All right, pediculosis capitis, so it's also known as head lice. Basically, it's just an infestation within that scalp by a parasite. Very common in kids, at more close contact settings, think of schools and daycares. This is basically like those tiny insects. It just feeds on the blood from the scalp, basically, and then that is what leads to it being very irritating and itchy as well. So basically, like patho-wise, so the lice, it infests within the hair on the scalp, basically where they feed on blood. But as they feed, how I mentioned, it causes that itching and irritation. But then the lice lays eggs or nits. So the nits are called eggs on the hair shafts and near the scalp, basically. And then those nits or the eggs, it'll hatch in about 7 to 10 days. And then that cycle continues. So that's why it's important to remove all of it. And then basically that itching, it's just like an allergic reaction, basically, to like the bites, the lice bites. In terms of cause, how I mentioned, it's like head-to-head contact. So any kids that are in close contact with someone who has lice. In terms of like indirect contact, that can be like sharing those clothing, hats, bedding. But it's still possible. It's not as common, but it's still possible. So yeah, in terms of findings, we talked about the itching. You may actually see the nits or the eggs on the scalp if you're looking close enough. So it's like more small, oval, like white and gray in color. And then in terms of treatment, so typically permethrin or a topical pediculicide that is commonly used to treat lice. And then if after, like 7 to 10 days, a second treatment may be needed to help if it's not working. And then in terms of using that pediculicide, you also want to use, they usually come with like a specific comb as well in the inpatient setting. It's like a fine tooth comb that helps remove those nits or those eggs from the hair, so that you can prevent that reinfestation, basically. And then also wanting to educate, they need to clean their bedding, clothing, personal items in hot water to kill any of those like lice or the nits, again, eggs. And then also educating to them that they need to vacuum any areas that may have been in contact with like that infested person. So being able to educate, in terms of preventing, avoid sharing those types of personal items, combs, hats, hair accessories, brushes, and whatnot. And then in terms of like if they are in school, these kids, they need to stay home from school until their treatment is started, until they start using that shampoo, the permethrin. All right, pediculosis pubis. So basically the same thing, but it's just found in a different area. Okay, in terms of findings, the same. In terms of treatment, too. Misconception, you are not going to see any lice flying, jumping, and whatnot. All right, let's move on to Lyme disease. So this is a vector-borne illness. So most commonly caused by Borrelia burgdorferi. So basically, it's just when a tick bites you, and then that's what leads to it. So it's more common in those that are like 5 to 14 years old. And then in terms of this, that bacteria, how I mentioned, the Borrelia burgdorferi, whatever. So through that tick bite, once that tick, bites or feeds on the child, basically that bacterium, it gets injected into their blood or like their bloodstream, and then that can lead to all these symptoms that we're going to mention. In terms of diagnosing this, so what you're going to see, it's usually a 2-step lab test. So it could be an enzyme immunoassay, or EIA, or an indirect fluorescent antibody, so IFA, to detect those antibodies. And then if it's positive, then they're going to proceed with a Western immunoblot, so that will confirm the diagnosis. In terms of management, it's antibiotics. So those that are under 8 years old, they're going to be prescribed amoxicillin. For those over 8 is doxycycline. And then in terms of the stages, so there's 3 stages that it can progress to. So first, early localized. So this is about like 7 to 10 days after the tick bite. And then what you're going to see is typically just one red circular rash with a central clearing. So it looks like a bullseye, basically a bullseye rash. And they may exhibit, no, that's basically what you're going to see. So that rash is erythema migrans. And then the second stage, early disseminated stage, this is about maybe weeks to like a month after that infection or that bite. This is where that bacteria is spreading, and it causes more rashes and more symptoms. So you're going to see multiple of those erythema migrans now. And then you may see all those symptoms that are listed on that slide. And then if it's untreated months to years after, this can lead to that late stage or late disease. And this is what can cause chronic arthritis, so particularly in the knees, and then potential like neural symptoms as well, like memory issues or difficulty concentrating. So it's very important to be able to monitor and also treat this effectively and appropriately, okay? In terms of prevention, you want to be able to educate about this, using insect repellents on the skin and clothing, wearing protective clothing if you are in areas where it is known to have more tick bites and whatnot. So like long sleeves and pants. And then being able, like when you're doing the outdoor activities, when you're in those areas like wooded or grassy areas, performing like tick checks so that you can look for it. But yeah, if it is found, those are the steps to how to remove it, making sure you can use like tweezers to be able to remove it fully too. All right, let's move on to scabies. So this is a contagious skin condition. It's caused by a mite called Sarcoptes scabiei. I don't know if I said that correctly, but basically what this mite does, it'll like burrow into the skin, and then that is what causes that itching and that rash that is very commonly known with scabies. In terms of this, the symptoms is pruritus, so very intense itching at night, and then that rash, it usually looks like small red bumps or blisters, burrows. And then in terms of like where it's located, hands, wrists, elbows, armpits, everything that's listed on the slide: genital area, feet, knees, scalp, face, palms, and soles. Okay, but if the itching, how it causes intense itching, this can lead to a secondary bacteria infection. So want to be able to monitor that. Okay. In terms of treatment, so usually permethrin 5% cream. Okay, it's usually applied to the entire body, neck down, and left on for about like 8 to 14 hours before being washed off. And then if there are like newly hatched mites and whatnot, they may need a second treatment to help with like the itching and the inflammation. They may be prescribed an oral antihistamine or maybe a topical corticosteroid in addition to that permethrin. In terms of education, to be able to prevent, or also like in terms of like the treatment, just avoiding skin to skin contact with someone who has scabies. You want to prevent the spread. Being able to educate about sharing personal items, hats, combs, bedding, I mentioned this earlier too. Cleaning those personal items in hot water to help prevent that reinfestation too. Again, just like the previous slide. So, to avoid like reinfection, so anyone that kid lives with, any close contacts to, they should be treated simultaneously too, to be able to again avoid the reinfection and the spread. Thinking about scabies, there is a social stigma to this, especially in kids. So when you have a kid with scabies, you want to be able to help them to feel like normal during treatment, even like with the head lice as well. So that being able to educate to them and to parents, like this is treatable, as long as they're compliant with the permethrin, being able to prevent spread too, so it's not just like a cycle that's happening. So just being able to do that, it's not just a reflection, or it isn't a reflection of like poor hygiene, it's due to a mite. Okay. All right, so human bites, animal bites. So in terms of human bites, you want to be able to distinguish between, is this from rough play with another child, or is this a possible child abuse case? Okay, so being able to do a proper skin assessment head to toe with another, like a second RN, asking your history questions. Does it align with these bites? Do you see teeth marks and then they say like, oh, they fell off the playground? Like, does it coincide with history with what you are seeing within your physical assessment? And then being able to take the necessary steps. We are mandated reporters, following the guidelines of what you would do within that hospital or organization. Being able to document it appropriately. If it's like deep enough, those lacerations, what are we going to do for wound care? What are the orders? Being able to take pictures of it and then document it on the patient's chart too. There's a whole process to that. You want to keep that area clean to prevent any infection there. In terms of animal bites, so most common are dogs and cats, and then I see a lot in the face area. So this goes alongside with like anticipatory guidance, always having supervision with animals around kids, even if it's their pets or anything like that. You never know, if it was like an accident or if it was provoked. Kids are super curious, or sometimes if they accidentally pull, tug, or step on something, or if they like scare that specific animal and it was just like a reaction, those things can lead to these types of bites. And when it's more deeper or more severe, more care goes into it. They may need antibiotics. Maybe they may need a vaccination, wound care too, keeping that area clean, thinking about pain management as well, and how traumatizing this can be for the kid as well, and then also body image. All right, and then burns also coincides with anticipatory guidance. Can this be prevented? Was this intentional or not? So, taking a look at all these pictures. So, the bottom right corner, you see how it's mainly like the legs and the buttocks area. So, you want to think of, oh, were they submerged in really hot bath water? Was it intentional, or did parents just not check and just plop their kid in the bath water? Thinking about as toddlers are walking more and they're getting taller and they can reach things that are on counters or on stovetops, being able to prevent that turning the handle too. Okay. um, and then in terms of like wound care for this too, it's very important keeping it clean, following wound care orders. If it becomes blistering, you don't want to pop it. If it becomes open, then it increases that risk for infection. And depending on what area is burned, if it's more of that upper body or like the face, you want to think about airway immediately, because you don't know, like, oh, did they swallow hot water too, or were they exposed, like if it's like in a fire. That can happen too. So always thinking about airway too. So your ABCs, being able to prioritize airway management. And then yep, just being able to educate to parents too about how to prevent this. Again, how I mentioned, anticipatory guidance. All right, here are some questions for you to be able to practice and see where you're at, if you got a good understanding of the lecture and your readings through the chapters as well. So this case study, an 11-year-old female presents to the emergency department. So upon their physical assessment, they note the following. So what do you see? What do you suspect? What's the treatment? And what education would you provide? So pause. Try to answer that. Look back into the slides to find the answers, okay? This is the next case study. So a 6-year-old male presents with a temperature of 100.7 Fahrenheit, axillary. They are fatigued and they have a headache. So when they examine the kid, they have multiple ring-like rashes on both of their lower extremities. So what infection do you suspect? What stage? What therapeutic management would be prescribed and why? Take a look at these pictures. Are you able to identify which skin disorders these are? What are common findings with this? What is the management? Any education that you can provide? All right, that is the end of this lecture. Please feel free to contact me if you have any questions. And yeah, have a great week, and I will see you next week. Bye.